I'd like to introduce Helen Keleher. Helen's our first keynote speaker. Helen is an adjunct professor in health science and School of Public Health and Preventive Medicine at Monash University. Until recently, she was Director of Population Health at the Frankston Mornington Peninsula Medicare Local. Helen's been a member of the Women and Gender Equity Knowledge Network for the World Health Organization Commission on Social Determinants of Health, and a past president of the Public Health Association of Australia. She's co-editor of two popular texts, Understanding Health and Understanding the Australian Healthcare System. And Helen's work over many decades has been about understanding how we can best affect change in the determinants of health, health equity, and especially through place-based collective impact strategies. Today, Helen's here to share with us and explore the topic that David announced of big data and our rural and regional areas such as ours ready for big data and how we can use big data to transform healthcare and healthcare outcomes. And I'm particularly interested in that in relation to social determinants. Thanks.
It would be a good start, wouldn't it be, to trip over the microphone and make an entrance that way. Thanks very much, David. And David, I'm really delighted to be here and talk about a topic that I've learned, I suppose, from being in that very applied world of a Medicare local, and making the connections that David was referring to before between the research work that academics are consumed in doing and publishing, and then transferring that kind of knowledge to action, which is what Medicare locals were about, and which we all hope the new primary health networks continue to develop. So I don't want to, my daughter said, Mum, you start talking about data, they'll all go to sleep. So if there's any risk of that, just raise your hand and I'll try and get more interesting. But I'm not going to bore you with a whole lot of data slides. I want to talk about the opportunities for this alliance, as David number 2 said, and David number 1, that you have in this particular alliance to harness the tools that are becoming available to us. So one of the issues that consumes, I'm sure, all of you in a rural area, any rural area is the same, so our cities for that matter, it's the distribution of health and well-being in particular, and but of course illness is part of that. We know that it's unevenly distributed, we don't always know what we can do about it, and we're consumed by the issues that are in our face because that's what we have to deal with. But if we take a social determinants approach, and I'm delighted to see so much emphasis in the program on the social determinants, which means it's really captured our thinking. It's actually about these bigger issues. It's about early childhood and education. It's about the social gradient. It's about access to health and social services, poverty, low incomes, the food security and nutrition issues that affect so many people, and particularly children, social support, gendered aspects of health and wellbeing, culture I haven't put on there. Some people include addiction. There's a range. None of them work in isolation. They are all important. But how we capture those into our thinking about bigger picture planning is the huge challenge that we've got. You can look at a list, you can do research on gender or do research on early childhood, but we actually need to understand how we can paint a picture, tell a story about a small area that is not doing so well, and that's where big data has a role to play. So this is a snapshot of the Barwon South East region by what's called the CEFA index, the socioeconomic index, for areas where the darker red areas are those classified as the most disadvantaged, and on some of them it's blue, blue for doing well. This comes out as pale blue. It's not too bad. I took this snapshot from the National Diabetes Scheme maps. They have fantastic maps, fantastic data attached to that. They're an organisation that's really working in a good data warehousing kind of way. But it does tell us where our areas of concern are in any catchment. This one's very red, isn't it? And I've got some other maps that show how we can use these tools to overlay information to capture much more than just a static map, because at this stage this is just a static map, and all it tells us is, you know, where are the more disadvantaged areas. It doesn't tell us enough yet. So how are we measuring disadvantage? The most recent Vinson report called Dropping Off the Edge came out about 3 weeks ago and tells us where the, you know, what the Herald Sun or any other newspaper picks up is, you know, what are the most disadvantaged suburbs. I live on the Mornington Peninsula. Frankston North has slipped, if you like, or advanced to become the third most disadvantaged suburb in Victoria, which means we're failing the people of North Frankston actually. We're failing the children especially. And that, I think it's important to understand that when that happens, we have to take responsibility for not working in ways that are making a difference. When on every score, we can see, sorry, this is now warming up and starting to be jumpy as I wave it around. I have to be careful not to touch. On all of those things, it is worse in some areas. None of them, again, stands alone. It's really important that we understand the relationships. So what big data can do for us, and I'll get to that, is help us to understand the relationships and where we need to make our investment, our health investments in health and social services, where the research gaps are, and what we're going to do about translating that into action. So I'm not going to go through all the social determinants, but I want to just layer in some kind of data thinking. And this is the first one, that we have to understand the social gradient in its rawness, if you like, and layer in the other things on top of that. But the household by income group shows a very clear social gradient in health. So does the data on smoking. And I've got a later slide that shows where smoking rates are most concentrated in your catchment. The most disadvantaged suburbs are double the more advantaged areas. I could ask you, 10 quick questions about where are the highest rates of smoking in your catchment, but I'll answer that. I think the highest rate of smoking in the state is Robinvale, where 41% of people smoke. That's nearly half. That's nearly half. It's just mind-blowing. Frankston's 32%, and I've got yours, so hold your breath. But what this shows us is that 15.1% of the least disadvantaged smoke 30.1%. This is for males. Smoke for women, it's 9.5% and 21%, which is more than double. So we know that women who are more disadvantaged have higher rates of smoking, but this only shows us for males over 18. They don't actually take up smoking over the 18. Mostly they're not taking up smoking at 18. Mostly they've started at when? 10, 12. That's right. So addiction kicks in a lot earlier than that. The habit is a lot earlier than that. So, we need to keep that in mind when we're thinking about our resourcing. So here we are. Here are your smoking rates. I love this data. It only came out last October, and it gives us the data by statistical area 2. It's available on the Public Health Information Development Unit website on an Excel spreadsheet. I got very excited, and I sent an email around to my colleagues and said, here's some data that'll rock your socks for Frankston and the Mornington Peninsula, and here's your data, and I think it does rock your socks, especially this one. In your primary health network catchment, you've got 95,500 smokers. My word, that's a lot of lung disease. It's a lot of poor bone health and a lot of cancer, isn't it? Shocking. It's just shocking. And the highest then is not unexpectedly Corio and Nor Lane, but some of these others are quite significant too, where there are larger populations. There is some Newcombe, again, not 29%. These are modelled estimates, nonetheless. They're pretty jolly good because, every time the marketing companies have the data on sales. They know where cigarettes are being sold. It's pretty easy for governments to get. Victorian government does have that data, so that the model estimates are actually pretty accurate. So there's a lot of work to do in understanding the importance of this is not about smoking, this is about small area data. What we're getting now increasingly is data at more local levels, and that it's very exciting, and it's much, much more sensitive for us in terms of understanding what we need to do. Deprivation of health, you'd be familiar with this. There's all established associations between most causes of most major health conditions that are on that social gradient. I'm not going to go through them all. I will point this one out though. I haven't had time to look up what your avoidable hospitalisations are for type 2 diabetes for the whole area. I've got it for Barwon in the southwest, but for the southern region, which stretches from Port Melbourne to Port Said over to Casey and Cardinia, there were in 1 year, 2011-12, 152. I actually do guess the data one often with this one, but I won't put you through that because you'll be wrong. There were people say, so how many bed days that are classified as avoidable hospitalisations are there for type 2 diabetes in 1 year in your region? And they go, 25,000, 30? No, it was 152,000 bed days in one region for one condition that's classified as avoidable. It's stunning, isn't it? You kind of go, my God, how does that happen? The point is that we need to strengthen primary care. We know what the research is telling us, but we're actually not putting the resources where we need them most to keep people out of hospital so hospitals can do other things. And there's a perverse incentive, isn't there, David, that hospitals are paid to admit people. You have to get over it. But I know Barwon Health is doing a lot in this space. I've had a conversation with David not long ago about the work on segmenting the population, understanding risk, and that's exactly the kind of work that needs to happen, be scaled up for us to understand a whole lot more. If you understood this data at a small area level, you would be able to target resources much, much more effectively. We need to know where the good primary care work is going on and where it's not so good. We need to know where the high-risk people are, and we need to be targeting those resources into those areas. Okay, another one I think that we need to take have very good understanding of, and I wonder how well we do this yet, is understanding early childhood. And we can do that on a scale, again, on the 5 levels of disadvantage, which this slide shows. Are you familiar with the Australian Early Development Census, the Australian Early Development Index? A few? Who's not familiar? Do I need to explain it? It's run through the Murdoch Children's Institute. It's funded by the Commonwealth. It started in 2009. We had another census in 2012, and we've just had one this year. I think that's right, isn't it? And every child in prep is surveyed within the first month of them entering school, and it's what teachers are measuring is their school readiness on 5 domains with a whole range of subdomains. It's rigorous. It's being used in a number of other countries. It's world-class data. It's world-class research. It was called the AEDI. It's now called the AEDC. Data is then provided to schools. They get their own report, but you can get data for areas from the website. But you can also approach the schools in your area to find out what they need. Now, the data that is important is how many children in that school are developmentally vulnerable on 1 or more domains or 2 or more domains. And, what does that tell us? It tells us what that school needs in terms of resourcing, but it also tells us how well or not we've been doing in early childhood in that area in the years before. So I'm going to come back to this because I think this is a litmus test for how well we're doing and how well we're going to do in health in the future, because those children are our next generations. And if we don't attend to the early intervention, if we don't build that into all the work we're doing, then we're just feeding the tsunami of poor health that's coming. So this is really important data, and the point about this slide is that it tells us that the children with the highest levels of developmental delay are happening in the more disadvantaged areas. Surprise, surprise. Sometimes that's because the practitioners aren't there to work with them. Sometimes it's because it is about poverty, poor parenting, low literacy and so on. Right. Diabetes, here you are. This is the number of bed days. Again, this slide tells us, this is about avoidable admissions classified as avoidable. It tells us that more people are, oh God, I smashed my thumb in the car door. It's now deformed and it's too big for the little thingy here. No, it's all right. Thanks, David. But it will come back to normality, my thumb. It just takes a year, doesn't it? And it's very painful. So the avoidable admissions are also running along that pattern of the social gradient. We know that there are more avoidable admissions in the more disadvantaged areas. And we need to do a lot about that. There's a lot we need to do. So you've got 20 per 1,000 people. It's the standardised rate for Victoria. Here you've got 21 higher. It's not significantly higher, but it's still higher for particular areas. That's the kind of thing that we can map into our big data. Your diabetes by postcode, is this any surprise? This is a very small population here around Wollora, 59, but 9.1%. That's about ageing, isn't it, I imagine. But you can look at some of these other areas where it's significantly higher than the average in Victoria, which is 5%. And what it tells us is where we need to be doing our work on chronic disease, absolutely, into those small areas. Okay, so what's the issue with data? Well, to get that data, I had to go all over the shop. I had to go to this spreadsheet and that one, that website, find that map, try and construct maps. There's too much data, there's too little data, it's in static places, it's in interactive places, some of it's out of date. There's no point getting the diabetes data from the public, it's called the FIDO database, because it's out of date. You've got to go to the National Diabetes Service to get the up-to-date data. It's everywhere. And it's in different forms. It's often inaccessible. There's a fabulous new database I've got on, just referring to on another slide, called AURIN, the Australian Urban Research Infrastructure Network. It's fantastic, but you're going to get into it if you're in a university. So, you know, it's not accessible to people who might want that information beyond universities. It's also presented in ways that don't allow us to mine it. One of the problems with AURIN, well, it's not a problem with AURIN, but it's not designed for local level people to upload information. The kind of data warehousing that we want is information that we want to have control. So it needs to be, you know, we need to be able to download big statewide databases into it, but we also need to upload smaller ones. We need to have that capacity. So they need to be able to be mined in the ways that we want it. We need to be able to get in and interrogate the data as well as upload it and make sure we've got a good warehousing system around it. Does that make sense? So mostly traditional storage environments for data don't work for us. Where are those storage environments? Oh God, they're everywhere, aren't they? And it's very time consuming and inefficient that they are. I acknowledge that Barwon Health, amongst a number of other health services in Australia, are now warehousing their inpatient data, outpatient data as well. It's confined to the health service, but I think we can build on it. We absolutely can build on it to include this population health level data, the social determinants information that we need. To layer into that, it can work from primary care through to research to create a bridge for that knowledge action gap. So the traditional storage environments are very passé now. There are too few people with good data mining skills. So while I was with the Medicare Local, I was really keen to find out what population health people are doing. We ran, I think we had 2 or 3 national workshops. I wanted to know, who were these people? This is an emerging discipline in population health and data. So I surveyed them in June, just before everything went, you know, pear-shaped in Medicare Locals, before they all started leaving and finding new jobs. And they came from a whole range of disparate backgrounds. A lot came from public health, a lot came from planning, a lot came from nothing in particular, and most of them were learning on the job. So we're not teaching how to do this work yet either. Hello, universities in your public health courses. These are new areas that we need to teach. They're actually not all that new, but they're new techniques. And it's a new way of thinking about how we can actually bridge that knowledge action gap. And it's time we did teach them and taught them well. So you can go into a planning course and learn GIS. I had a student I had a data analyst who was doing an MPH, and he accessed a unit in visualisation, data visualisation. I love that. Saying, Ryan, what does that mean? And I'll show you some products of what he did for his assignments in data visualisation shortly. So we need to understand who we're employing to do this work, that they've got the skills to do it, and we need to understand that a lot of the traditional kind of data sets that we've got are not predictive, they're just reactionary, that we actually need our data to be put together in a way that allows us to be predictive. So, big data, that's the answer. I had on this slide, who are you going to call? My daughter took it off. She said, oh no, Mum, you can't say that. Data doesn't talk to you like that. And I said, it so does. It does, talks to me. So it's a relatively new concept in health, and I should say that big data, when you're an IT geek, means, you know, what the telcos are arguing with the Attorney General about. That's not what we're talking about. You know, big mining companies, you know, big oil and gas companies and all that, they work in seriously big data, and they need seriously strong security systems around them because they could be hacked, and, you know, you see that kind of thing hitting the press from time to time. And we're not talking big tetrabytes of data. But in health we are talking about the ways of putting data together that creates a much bigger data system for us to use. So it's about how we're putting data together, how we're putting information together that can be warehoused and then enables us to pull it out and make sense of what before was quite disparate information. So they have add-on tools, and I'll show you a couple of ways that they present information that allow us to mine it, to, you know, ask questions of it, see if we take that and we take that. Let's take all the diabetics in one area and then we look at the primary care data and see, well, how many people are actually being treated regularly for chronic kidney disease? And you can get that from MBS. So, you know, are we actually treating sufficiently around the conditions that are costing the health system a lot of money? All of that can happen. We can visualise them into maps, so you can present a whole lot of data in a really dry way and everybody goes to sleep. But you put it on a map and tell a story and they go, whoa, I didn't realise that. And you say, well, I just told you in words. But when they see it, they go, wow, that's amazing. So I'm going to show you some of those in a minute that Ryan did. I don't actually know. I should say I don't actually know how to do that, but he did, and it was fantastic. So we need to draw those insights out. So it delivers capability. Now, we're used to hearing academics talk about data linkage. The school that I'm an adjunct with, I used to work in, is obsessed with data linkage. Sweden does it well, Norway does it well. So you can take, you know, data from one place, pull it together with another, link it together and find out a bit more about the problem. I'm trying to think of somewhere that does that well, data linkage. Interrupt me if you can think of one. But, you know, it's a common discussion to be able to say, how can we take the Department of Human Services, Health and Human Services data on, you know, their Victorian Admissions and Emergency Data Set or whatever it's called, the VAED, and link that to something else. It's not enough. We need to blend all of that information into a single platform. And then we transform it. The tools that are then used to make sense of that, transform it into, that allow us to have different insights. And then it can be mined and interrogated. Data is only data unless you ask questions of it. We need to have the skills and the imagination to interrogate it properly. And then we have knowledge. Up until that point, it's just a whole lot of disparate information, but we have to turn that into knowledge, and then we need to turn knowledge into action through good planning. So this is partly around data analytics. It's where health system and data analytics come together. We must be able to interrogate the information, as I said, and then knowledge becomes power, and we harness the volume of all of that information that's out there to turn it into that forward thinking. This is what business is doing constantly. We're not nearly there in health yet. So I mentioned about the proactive decision making, the predictive modelling that's starting to happen, especially around chronic disease and avoidable admissions. The data mining that I've mentioned, the forecasting, the statistical analysis. We can then see trends. We can see weaknesses in our health service delivery and at the funding, how we're distributing funding around, and making decisions for the future. So I talked before about visualisations. There are tools then that allow us to visualise the relationships between different sources of information. And that's a fairly static one. But you can see that what's here is that you could have Excel files, CSV, XML, custom, ad hoc, relational. You can have all kinds of different data. You just need a common platform. What I'm going to talk about shortly just needs Excel files. So if the data can be turned into an Excel file, it can be uploaded. It's called Portal. It's developed by one of the Medicare locals. Anything can be uploaded into that in an Excel file. It's brilliant, absolutely fantastic. And then what you can do with a program called ClickView, and there are others like this, it's just that I'm familiar with ClickView. This is what you can pull out. Now, ML Portal belongs to the Inner East Medicare local, which is just struggling a little to become a PHN. So it actually almost doesn't exist at the moment, and no one's got really using the data. I did ring the director and said, can we, where is it? And he said, it's a bit in abeyance. So, and I don't have access to it. I'd have to have a licensing agreement to do that. We had one with the Medicare local, but as an individual now, I'm a consultant. There wasn't time for me to get a licence up with an organisation that doesn't know legally where it sits. So I thought, okay, I'll just forget that. But I would have pulled out a screenshot of general practice data, some socioeconomic data, and some health department data to show you the possibilities. So what we were doing was showing all our, it's got all the Ambulance Victoria are uploading their information into it now. Has anybody seen it? Has anybody used it? No. PHN, Medicare local people? No? Yes? Yeah? It's great, isn't it? Not nearly enough in it though, is there? Not nearly enough. There's so much more capacity. So it will give you can have your maps, your charts, pie charts. You put in the values that you want to draw out. You can have patient populations by practices down here. You can have all kinds. These will all represent some other aspect of the questions that you're asking. And what it shows you is a relationship between all those previously disparate bits of data to give you a much stronger picture. So we wanted to get the titanium data there from Dental Health Services Victoria. So I took some staff from DHSV out to the Medicare local a couple of years ago, and they were demonstrating what they could do with it. And they said, so Box Hill Hospital are wanting to know why they get so many cases of diarrhoea between 9 and 12 in the morning on weekdays. So they looked that up, and where do they come from? They come from the western suburbs. Why is that? They're coming in with diarrhoea. Well, no emergency department likes diarrhoea coming in anyway. Please stay home and look after it quietly, unless you're really dehydrated. Then we've got a job to do. But really, these were bypassing primary care as well. They were bypassing open general practice clinics. Why is that so? Why are they coming from the western suburbs? That is the question, who knows? But it was fascinating that the majority through the week were coming from way out of their area. Probably something to do with transporting food and goods across the suburbs, I don't know. But anyway, ClickView can help you pull out the data and make sense of it in ways that you've never dreamed before. It's brilliant. Now, there are some examples. So the Medicare local one that Inner East developed is now called POLAR, which stands for Population Level Analysis of Reporting. Now, it wanted to use PenCat. Who's familiar with PenCat? Very few. Okay, so PenCat is a tool that has been used by divisions of general practice, and it is run out of Central Adelaide. I don't know what they're calling themselves now, that they're a PHN, but I think there's still a division business happening through that owns and runs PenCat. there are some issues between... PenCat have not been able to give permission to the data warehouse, which is called Polar, to put the data in and turn it into big data. They won't let the data out of the practice. So you can only get practice level data, which is quite interesting if you're in a practice, but actually what we want is to see what's happening in a catchment. We want to see what's happening in a bigger picture. But it's also a bit... it's restricted in how it operates. It only uses 40 disease categories. So they started talking to people at Melbourne University around a program called Granite, which is much, much more sophisticated. Look it up. It uses the CSIRO SNOMED disease category, so it's kind of everything in their dog that's in there. And it's a real-time... It draws data out of practices in real time off one central computer. It's all de-identified, and it goes back into the data warehouse to be, to be available to be mined in whatever way you want. And it is the way of the future. There's a number of research studies that have been hanging off that. There's one called Magnet, which has been running in the eastern suburbs through Monash Department of General Practice. But Granite, again, it's a tool, but it's one that makes the data available into the data warehouse. And that means the practices can pull out real-time reports every day, every half an hour if they want. The warehouse then has that data going in and being updated as often as you set it to be updated. It uses ClickView, and they've been negotiating with ClickView for a good license deal because so many practices were using it. So this is a fantastic data warehouse, but it also means that Medicare locals could upload their own information as well. So I said it had that top-down, bottom-up facility. Or, and as I said before, it's worth having a look at, see if you can get access to. It's cost $24 million funded by the Commonwealth through one of their research grants. I think it was, I might get into trouble if I say the wrong research scheme, but they got that funding for. That's a lot of money, $24 million. Your alliance should be able to get, it actually doesn't cost that much to build something like a data warehouse, to build a data warehouse with that kind of facility. And ML Portal exists. The portal exists. So, it's a question of how you negotiate to get access to that, to build it, to make it what you want it to be. I wanted to make the note that if anybody asks, PenCat is not about big data. So what? It makes us smarter. It is about integration of information. It's about organisations being more agile and able to respond. You need to write a submission about something and you've got a question about information that you want to pull out. It's just there. You can just go to it and make it happen. Or you've got a place in your alliance, university, PHN, wherever you decide it should be, that you can go to and have people pull that out. I mean, you only need one or two people to be running this. You don't want to all have to sit around and kind of try and learn how to use it if you're not techie minded. But you need to know who are the go-to people who can actually pull that data out and help you get on with what you need to do. So it's not the storage and the existence of the data, it's what you do with it that's important, but you still need to have the storage facility. Having those insights mean you can have a profound effect on the way resources are used, and it is very much about promoting evidence-based decision making. Come on. Here we go. So this is about population health, which is my favourite subject in the whole world. Population health is about the social determinants. It is about all of those. I'm not going to go into the social determinants because I'm assuming that you've got an understanding about it, but it is about understanding the features of the social context where illness is happening at greater levels, where health and well-being is lower. That's what it's about, and the pathways that take us there. So, here's an example. I've got a few examples then, and about 5 minutes to show you. So it's about relationships. It's about relationships with data that makes it more meaningful. You can ask a data warehouse to explain where are the general practitioners in an area, the allied health practitioners, and overlay that on your CEPHA map. You can add the location of health services onto that map, as I've said, and then you can overlay that with treatment patterns for priority conditions. Where is this happening well? Where do we need to do some professional development with general practices to make sure we're treating it? Let's use chronic kidney disease as an example. Now, we asked the question in the Frankston-Mornington Peninsula area about where are the registered GPs to deal with registered drug clients, and where are the pharmacies registered to dispense? Because we have a huge problem in Frankston and the Mornington Peninsula with, Frankston rivals Footscray and Ringwood for being a hub, a honeypot for drug use. And there are a number of reasons for that. But we felt that we just didn't know where the services were. Were people who are flocking to Frankston able to get the kind of treatment that they need? And the answer really is one that people have been asking for a long time. There is one general practice close to the railway station in Frankston that has 1,100 registered drug clients. The other GPs don't want to know them, the clients, so they all are with this one. Interesting, isn't it? The department's preference is that for each practice to have no more than 5 or 10 to 10. But it's a very interesting phenomenon. So Ryan did this, as I said before, for his visualisation unit. Now this is the blue belt, Blackrock, Beaumaris, Hampton. In this particular map, yellow is more advantaged and red is more disadvantaged. So we're heading here out east, Clayton, and I'm going to show you Dandenong in a minute. The yellow buttons represent registered pharmacies who can dispense methadone or whatever, and the blue are the GPs who are registered and have clients, registered to have clients. So there's quite a lot, isn't there? Thing is though, there's not many clients in that area. There's an awful lot of providers. Let's have a look at the next one. So as we go further out, oh come on, there we are. You can see the red increasing. There's quite a few around Clayton, Springvale, Bentley. There's a lot around this nice middle belt here, isn't there? Malvern, Malvern East, Bentley. A lot of providers, not many clients actually. And the further out you go, the fewer registered providers there are, and the further out you go, the worse it is. So there's a lot around Springvale, but the further out you go, and there's actually big problems out here in the newer suburbs, Pakenham, Cranbourne, a lot of problems, but not many providers. That picture tells 1,000 story. The department went, oh, goodness me. So when we put in our submissions, when the funding becomes available, we can use this kind of map to support our narrative. It tells a lot. Another one that we did was hepatitis C prevalence by location, and you could overlay a lot of information on this. So the blue areas have higher numbers of people. Look, I don't know what this 4, 7, 14, 11, 40 is. Don't ask me. I don't know. I didn't put it together. I can't work it out. But this is the prevalence. You might work it out, people with better data skills than me. The higher prevalence is in the blue areas. And so we know that there are 4,000 to 6,000 people in the Frankston City Council GP alcohol and drug practitioners estimate they're caring for 400 to 600 people living with chronic hepatitis C. 20% will go on to develop chronic liver disease, and there'll be a number of those who go on to develop liver cancer, and they'll then be on the list for transplants. You can see the predictive capacity of this. So are we treating that well? Do we have the practitioners in that area who can treat well and have the history of treating? They actually become very skilled and experienced in working with those clients? No, we don't. We really don't have those people in our area down here, which is what this was done for. So, you know, this is the kind of stuff that you can pull together. Great, isn't it? Early childhood. We absolutely need, G21's done a great report on growing up in the G21. It's fantastic, but we need actually to do much better. We need to be able to talk about caries rates, fluoride, the Australian Early Development Index, waiting lists for paediatric allied health. When we started at the Medicare Local, the waiting list for a paediatric speech therapist was 18 months in the public system. And we kept saying that is completely unacceptable, Peninsula Health, because they own Community Health, completely unacceptable. If a 3-year-old is waiting that long, that on their school readiness score, what's that going to say? And we also know that at Frankston North, in the primary schools, 68% of children were developmentally vulnerable on 2 domains. That's extraordinary. That's why it's in the most, top 3 disadvantaged suburbs in Victoria. And it had just become a norm that you had to wait in the public sector for a paediatric speech therapist. And we agitated so much about it that they actually put one on. And now the waiting time's about 8 weeks. Isn't that amazing? The solution is put on the staff. The solution to homelessness? Houses. Where did that come from? Such logic. So we need to actually also understand sole parent families. So this is the census data. We need to understand low-income families, jobless families. We need to know where they're living. And all of that is the picture that needs to be put together at a small area. And you can do that, mapping that, telling the narrative in whatever way, if that's all in a data warehouse. So let's be clear, it's a tool for telling stories, and that's what I've been doing, is telling stories about what it can do, but it's essential. And I think I've covered that point now, and I've got about 2 minutes left, so I'm going to push through. It's about imagining. It's about having a health imagination that takes in population health, the social determinants, the social data, obviously, and understanding that the drivers for health lie outside the health sector, so it's not only the health sector's responsibility. A lot of this is about local government, business, NGOs, the corporates, whatever. So to do that, everybody needs to be involved, and the key messages, I'm just going to finish off on this one. So it's combining data sets into this kind of warehousing system to do what we're calling big data is really exciting and new, and it's within our reach. The skills are out there, the software's available, it can be done. You've got such an opportunity to make this happen, and as David said, become the #1 academic health science centre, because I know that the other two in Victoria and the one in Sydney are very biomedical, and they're not getting into this level of analysis. They just don't have it's not where they're at. It's just not their thing. So data is just data until you actually have a public health imagination about it. You've got to ask the right research questions of it, and I'm sure you'll all be able to do that, but it absolutely transforms not only your thinking, but the people you're talking to. It can transform policy, it can transform practice. So it's an investment. It's absolutely the next investment that we need to make in better health outcomes. Thank you.